Assalamu alaikum everyone. Welcome to the class of minerals. Today we are going to be doing osteoporosis and calcium. We all know that in case of long-term deficiency of calcium, osteoporosis is developed in children, rickets develop, and in older age, osteoporosis develop. That is porosity of the bones. Bones become porous, they have calcium is withdrawn out of it, and hole like structures are formed. Thus, the bones become fragile. From this topic, we're going to learn describing the factors that contribute to the development of osteoporosis and strategies to prevent it. Osteoporosis becomes apparent during the later years, but it develops much earlier and without warning. So it is very difficult to see the early signs of calcium because the body has a very good hemostasis to maintain serum or blood calcium levels. But in case of deficiency, it does not become evident. Few people are aware that their bones are being robbed of their strength. So when there's a deficiency of calcium in the body, it is drawn out from the bones. The problem of 10 first often becomes evident when someone's hip suddenly gives way. People say she fell and broke her hip, but in actually the hip may have been so fragile that it broke before she fell. So fractures are the first sign of osteoporosis. Even bumping into a table may be enough to shatter a porous bone into fragments so numerous and scattered that they cannot be reassembled. So the fracture is it is not like a fracture, it is like when a glass falls to the floor and it gets into so many small fragments, the bone breaks into so many pieces like that. Removing them and replacing them with an artificial joint requires a major surgery. An estimated 258,000 people in US are hospitalized each year because of hip fractures related to osteoporosis. About 1 in 5 die of complications within a year. 1 in 3 will never walk or live independently again, and their quality of life slips downward. So, quality of life is reduced for these older adults who are not immobile and who cannot move upon their will. This highlight examines how low bone density and osteoporosis, one of the most prevalent diseases of aging, affecting an estimated 52 million people in the US, most of them women older than 50. So this disease is more prevalent in women and especially in older women. It reviews the many factors that contribute to the 2 million fractures in the bones of the hips, vertebrae, wrist, arms, ankles each year, and it represents strategies to reduce, paying special attention to the role of dietary calcium. Bone development and disintegration, how the bone is developed and how does it disintegrate or it becomes how it is dissolved. Bone has two compartments, the outer hard shell of the cortical bone and the inner lacy metric of trabecular bone. So the outer is called what? Cortical bone, and the inner called is trabecular bone. The outer bone is hard and the inner one is a little softer. Bone can lose minerals, but in different ways and at different rates. The first photograph in figure H12.1, let me see where that is. H12.1, the first figure shows the lacy network and the outer covering. Trabecular bone is a lacy network of calcium containing crystals that fill the interior. Cortical bone is the dense ivory like bone that forms the exterior shell. So you can see there's an inner part that is lacy and the outer part is hard. This is a transverse section, yeah, transverse section of the bone. The bone has been sliced into half vertically. Electron micrograph of a healthy tubercular bone and electron micrograph of a tubercular bone affected by osteoporosis. As you can see in the last picture, that the lacy matrix is very loose and it has lost calcium, and this is dense. It means that it has calcium intact. Then let me also show you the, okay. These crystals give up calcium to the blood when the diet runs short, and they take up calcium again when the supply is plentiful. So, in case of deficiency, calcium is withdrawn from the bones, and in case of plentiful in the diet, calcium is deposited. For people who have eaten calcium rich foods throughout the bone forming years of their youth, the bone forming years are from a young age till the age of 30. These deposits make bones dense and provide a rich reservoir of calcium. So, this acts as a bank of calcium. Surrounding and protecting the trabecular bone is a dense ivory like exterior shell, the cortical bone. Cortical bone composes the shafts of the long bones, and a thin cortical shell caps the ends of the bones too. So, cortical bone is all around the bones, but a thinner is at the end of the bone where it is adhered to the joint and where the other bone starts. Both compartments confer strength on bone. Cortical bone provides a sturdy outer wall, and trabecular bone provides support along lines of stress. The two types of bones handle calcium in different ways. Supplied with blood vessels and metabolically active, trabecular bone is sensitive to hormones that govern day-to-day deposits and withdrawal of calcium. So, the hormones responsible for withdrawal and deposit of calcium, trabecular bone is sensitive to that because it is supplied with blood supply. The cortical bone is not sensitive to the hormones. It readily gives up minerals whenever blood calcium needs replenishing. Losses of trabecular bone start becoming significant for men and women in their 30s, although losses can occur whenever calcium withdrawal exceeds deposits. Cortical bones also gives up calcium but slowly at a steady pace. Cortical bone losses typically begin at the age of 40 and continue slowly but surely thereafter. So, losses start from trabecular bone at the age of 30 and uh, from the cortical bone at the age of 40. As bone loss continues, bone density declines and osteoporosis become apparent. Bones become so fragile that even the body's own weight can overburden the spine. Vertebra may suddenly disintegrate and crush down, painfully pinching major nerves. So, our vertebral column may dissolve and crush down, pinching the nerves in between the bones of the vertebral column, or the vertebra may compress into wedge shapes, forming what is often called a Dowager's hump, the posture many adults assume as they grow shorter. So, you have seen that many elderly have a hump like feature in their back that's called a Dowager's hump, and that happens elder people stoop from their back and from their around their shoulders, and that is due to deficiency of calcium. Figure H12.2, page 402, shows the effect of compressed spinal cord on a woman's height and posture. So let us see that picture. Here is the picture. So the elderly woman that is more than 60 years of age, you can see a younger woman is standing upright, whereas the older woman's bones have disintegrated and compressed into each other, forming the dowager's bone over here. Because both the cortical and shell and the trabecular bone weakens, breaks most often occur in the hip, as mentioned in the introductory paragraph. Physicians can determine bone loss and diagnose osteoporosis by measuring bone density using dual energy X-ray absorptiometry, that is called DEXA scan. This DEXA scan is available in Pakistan and is available in many hospitals. They also consider risk factor for osteoporosis, including age, personal and family history of fractures, and physical inactivity. There are many other risk factors too. The table H12 one summarizes the major risk factors for osteoporosis. The more risk factors that apply to a person, the greater the chances of bone loss. Notice that several risk factors that are influential in development of osteoporosis, such as age, gender, and genetics, cannot be changed. So some factors can be changed. These factors are called modifiable factors, and some factors cannot be changed that are called non-modifiable factors. So the work of nutritionist is in the case of modifiable risk factors so that risk of individuals is reduced. Other factors such as diet, physical activity, body weight, smoking, and alcohol use are personal behaviors that can be changed by eating a calcium rich, well balanced diet, being physically active, abstaining from smoking and drinking alcohol in moderation, if at all. People can defend themselves against osteoporosis. These decisions are particularly important for those with other risk factors that cannot be changed. Whether a person develops osteoporosis seems to depend on the interaction of several factors, including nutrition. The strongest predictor of bone density is age. So, if we look at these factors, first we'll look at the non modifiable risk factors. The first factor is the being of female gender, age greater than 50 years, having a small bone frame, being in Asian, Hispanic, or from Latin America, family history of osteoporosis or fractures, personal history of fractures, estrogen deficiency in women that happens when after menopause, and testosterone deficiency in men. These are reproductive related hormones. If they are deficient, there can be osteoporosis. Modifiable risk factors are sedentary lifestyle. A person can have a active lifestyle. Diet inadequate in calcium and vitamin D. Diet excessive in protein, sodium, and caffeine. When we studied minerals, we saw that when a diet is high in protein and when the diet is high in sodium, uh, high protein and high sodium excretes calcium. Caffeine smoking, alcohol, cigarette smoking, alcohol abuse, low body weight, certain medications such as glucocorticoids, aluminum containing antacids, and anti seizure drugs. These medications also hinder with calcium absorption, thus causing calcium deficiency and osteoporosis. Low body weight. Body weight bearing exercises have been found to be beneficial for structuring of the bones. So research has also shown people who have more weight have lesser chances of osteoporosis and bone fractures. The woman on the left is about 50 years old, and on the right, she is 80 years old. Her legs have not grown shorter, instead, her back has lost length due to collapse of the spinal bones. Collapsed vertebra cannot protect the spinal nerves from pressure that causes excruciating means high pain. Age and bone calcium. Two major stages of life are critical in the development of osteoporosis. The first is the bone acquiring stage of childhood and adolescence. The second is the bone losing decades of late adulthood, especially in women after menopause. After menopause means that after their periods have stopped. The bones gain strength and density all through the growing years and into the young adulthood. As people age, cells that build bone gradually become less active, but those that dismantle bone continue working. The result is that bone loss exceeds bone formation. Some bone loss is inevitable, but losses can be curtailed by maximizing bone mass. So, the losses can be reduced by maximizing the bone mass. And how can the bone mass be maximized? There by improving our modifiable risk factors. To maximize bone mass, the diet must deliver an adequate supply of calcium during the first 3 decades of life. Till the age of 30, you need to drink ample amount of milk. Children and teens who consume milk products and get enough calcium have denser bones and than those with inadequate intakes. With little or no calcium from the diet, the body must depend on bone to supply calcium to the blood. Bone mass diminishes and bones lose their density and strength. When people reach the bone losing years of middle age, those who form dense bones during their youth have the advantage, and others are at a disadvantage and they lose their bones easily. So, how can we minimize bone loss? Not only does dietary calcium build strong bones in youth, but it remains important in protecting against losses in the later years. If we have an ample amount of calcium in the later years, the amount of calcium needed to maintain the normal blood levels and to maintain the normal functions of the body, it will be taken from the diet but not from the bones. Unfortunately, calcium intakes of older adults are typically low and calcium absorption declines after menopause. The kidneys do not activate vitamin D as well as they did earlier. Also, sunlight is needed to form vitamin D, and many older adults spend little or no time outdoors in the sunshine. So there are two mechanisms working over it. Vitamin D is not being activated, and older adults usually do not go in the sun. For these reasons, and because intakes of vitamin D are typically low anyway, blood levels of vitamin D decline. Some of the hormones that regulate bone and calcium metabolism, parathyroid hormone, calcitonin, and estrogen, also change with age and accelerate bone loss. Together, these age related factors contribute to bone loss, inefficient bone remodeling, restructuring, reduced calcium intakes, impaired calcium absorption, poor vitamin D status, and hormonal changes that favor bone withdrawal. So there are many factors that become evident with the age, and we have no control over hormones that are declining due to the age. Role of gender and hormones. After age, gender is the next stronger predictor of osteoporosis. The sex hormones play a major role in regulating the rate of bone turnover. Men have greater bone density than women at maturity. Even at the age of 30 and 40, men have more dense bones. And women have greater losses men in later life. So even in older age, women have more bone loss. Consequently, men develop bone problems about 10 years later than women, and women account for two or out of three cases of osteoporosis. So, almost 65 to 70% of the cases of osteoporosis are women. Menopause imperils women's health. Imperils means is very dangerous for women's health. Bone dwindles rapidly, dissolves, breakdowns rapidly when the hormone estrogen diminishes, and the hormone estrogen diminishes after the menopause and the menstruation ceases. The lack of estrogen contributes to the release of cytokines that produce inflammation and accelerate bone loss. Women may lose up to 20% of their bone mass during the 6 to 8 years following menopause. Eventually, losses taper off so that women again lose bone at the same rate as the men their age. So, bone loss is very rapid after the menopause, especially in the first 6 to 8 years. After that, they lose equal amount of bones after that. Losses of bone minerals continue throughout the remainder of a woman's lifetime, but not at the free fall pace of the menopause years. So afterwards, it is at a stable pace. Rapid bone losses also occur when young women's ovaries fail to produce enough estrogen, causing menstruation to cease. So, this can also happen. Osteoporosis can also happen in younger women who do not have an ample amount of estrogen that is being released and their menstruation have stopped. In some cases, diseased ovaries are to blame and must be removed. In others, the ovaries fail to produce sufficient estrogen because the women suffer from anorexia nervosa and have unreasonably restricted their body weight. So this can happen in women who are underweight and who have anorexia and who are not consuming ample amount of food and they have a very low body weight. The amenorrhea and low body weights. Amenorrhea means absence of menstruation, and low body weight explains much of the bone loss seen in these young women, even years after diagnosis and treatment. Estrogen therapy may help some women prevent further bone loss and reduce the incidence of fractures because estrogen therapy may increase the risk of breast cancer. Women must carefully weigh any potential benefits against the possible dangers. A combination of drugs or of hormone replacement, a drug may be most beneficial. So, only estrogen therapy may be used to prevent bone loss and reduce fractures, but estrogen therapy has also been found to be related to breast cancer, therefore, care must be taken. Several drug therapies have been developed to inhibit bone loss and enhance bone formation. The FDA have approved the following drugs to prevent and treat osteoporosis: biphosphates, calcitonin, estrogens, estrogen antagonist, and parathyroid hormone. Some women who choose not to use estrogen therapy turn to soy as an alternative treatment. Soy is a bean, so it is consumed as beans are consumed, cooked and eaten. Interestingly, the phytochemicals commonly found in soy mimic the actions of estrogen in the body. Research results have been mixed and controversial, but overall seem to indicate a lack of benefit for soy and its phytochemicals in helping to prevent the rapid bone losses of the menopause years. As is true of all herbal products, there may be risk associated with their use, and in case of soy, evidence is lacking that the benefits clearly outweigh the potential risk. Because the risk and benefits vary depending on each person's medical history, women should discuss soy options with their physicians. As in women, sex hormones appear to play a role in the men's bone loss as well. Other common causes of osteoporosis in men include corticosteroid use and alcohol abuse. These are other important factors that contribute to osteoporosis among men, although sex hormones are also related to bone loss. So, we are going to stop over here and we are going to continue our topic in the next class, inshallah. See you in the next class. Allah Hafiz.